Hello everyone, I'm Isra Muhammad. I'm a physiotherapist working in Sokoto State, Nigeria. This is my first time making this kind of recorded presentation, and it stemmed out of the need to make this. This presentation that I'm about to do, I did it first at an online platform where weekly presentations are being made based on physiotherapy related content. And unfortunately, that day, the presentation was not recorded, and many people reached out to me if they could have the recordings because they missed out on the timing. And I've been thinking about it for some while, and I decided to go ahead and make this recording. So, the topic of presentation is titled Unlocking the Jaw: Physiotherapy Approaches to Managing Trismus. Um, but before I begin, I would like us to I would like to ask, have you ever experienced a situation where you're just returning from work, school, exhausted, you get to the door, slot in the key, turn the door knob, the door refuses to open? Or it even gets to open but not wide enough for you to squeeze through and gain access to your home. Imagine how frustrating that situation can be. So here, let's look at the door as the jaw that refuses to open and allow you access into the mouth. Next, have you ever imagined what it is Have you ever imagined losing the ability to speak freely, smile, or even enjoy that favorite meals of ours because our jaw won't open? Or what happens when opening the mouth becomes difficult, eating, swallowing becomes an everyday struggle? So we can see that the mouth or the jaw is like the door that refuses to open at that point and how frustrated it will be. And the whole essence of this presentation is what to do to unlock the door that refuses to open, the solution. So we'll be discussing this topic. I'll be discussing this topic under the following headings. Christmas. I've been saying Christmas from the heading of the presentation. It's in simple terms, it means lockjaw or restriction in mouth opening, or in another terms, limitation in mouth opening. It is a time that is derived from the Greek word trismus, meaning gnashing or grinding, and it, in simple terms, it's defined as the inability to open the mouth completely due to reduced mandible mobility. Okay, so now we understand that trismus is a restriction in mouth opening. But before we be able to identify when there's a restriction, we have to know what the normal is. To know the normal, there's what we call the interincisal distance. In simple terms, it's just the distance between the upper incisor and the lower incisor, and it usually ranges from 35 to 45 millimeters, though this range varies across different literatures. In some literatures, it's even up to 60 millimeters. There is a sex variation where males are said to have a higher mouth opening than females, with an average of 50 millimeters. It usually equates to 2 to 3 finger width breadth width. What this means is, for an average person, putting 2 to 3 fingers, that's the when you put together the index, the middle, and the ring finger in the mouth, it should be able to fit into the mouth. Inability to do that signifies a level of trismus. There's what we call the lateral excursion, that's the side to side movement of the jaw. protrusion and retrusion is the forward and backward movement of the jaw. Then, how do we measure this mouth opening to know if it is normal or restricted? As I've explained earlier on, that there's the manual way, that's the 3-finger width test, which is the 2 to 3 finger breath width. For patients with Trismus, they cannot even fit in 2 fingers, and in severe cases, even a finger cannot fit in. It's obvious there's a lockjaw present. Then another way is using simple equipment like the ruler to measure, and usually the calibrations of measurements used is the millimeters. And then vernier caliper, as you can see in this picture, is also used to measure the interstitial distance. So what are the jaw functions? Elevation and depression, that's opening and closing of the mouth, protrusion and retrusion, forward and backward movement of the jaw, because all try moving your jaw forward and backward. Then the lateral movements, which is the lateral excursion, side to side movement of the jaw. And all these movements culminate together to help in functions like swallowing, chewing, speaking, and oral hygiene. And the most impacted function in patients that present with trismus is the oral hygiene, because all these functions, not just the oral hygiene, feeding is impacted because they cannot even open their mouth properly to feed well. So feeding is affected, oral hygiene, brushing of the teeth becomes difficult, and swallowing as well. So what is the anatomy? We've, we've now understood that trismus is limitation in mouth opening, and it involves the jaw. So the as physiotherapists, we know that for movement to occur in the body, we need the coordinated function, of muscles, the joints, the ligaments, fascia, and all. But here I'll focus more on the bones and the muscles, because primarily they are primarily affected in cases of trismus. There's the joint that is responsible for jaw function is the temporomandibular joint, what we call the temporomandibular joint, or TMJ in short. The temporomandibular joint is, as we can see in this picture, it's the union between the head, or the condyle of the mandible, and the glenoid fossa of the temporal part of the squamous part of the temporal bone. And also, this temporomandibular joint has 3 articulating surfaces: um, the head of the mandible or the condyle, the glenoid fossa, as well as this articular eminence. The essence is that between the head of the mandible and the glenoid fossa, there's what we know as the articular disc, which is this. It's it has a primary function during jaw movement, be it in opening or closing. It moves alongside the head of the mandible. Like in opening, the head of the mandible moves downward and forward. So it slides together with this articular disc. Failure of this articular disc to move during this movement could also result in restriction. Or if it moves and gets stuck at this articular eminence, it also could cause dislocation, which, if not treated early, could result in trismus. Then we have the muscles that are responsible for movements of the jaw. We have the 4 primary muscles known as muscles of mastication. They are divided into 2 groups. We have the mouth opening muscles and the mouth closing muscles. The mouth closing muscles are 3, and they are 10 times stronger than the mouth opening muscles. The mouth closing muscles include the temporalis, the medial pterygoid, and the masseter, as you can see in this picture. And we also have the lateral, and all of them insert at different points on the mandible, on the parts of the mandible. Then we also have the mouth opening muscle, which is the amongst the muscles of mastication is only the lateral pterygoid, and this lateral pterygoid inserts um, to the head of the mandible, the condyle of the mandible. And so imagine if anything affects the head of the mandible, will indirectly affect that muscle and can result in trismus. So for the mouth opening muscles, is also assisted by some of the neck muscles like the mylohyoid, anterior belly of digastric, sternlohyoid, superior belly of omohyoid, and thyrohyoid. And mostly in trismus, spasm of this one group of muscles will cause reflex activation of the opposite muscles, which will result in tense or tight muscles, and then restriction in movement, opening of the mouth. Then also we have intra-articular causes. There's causes within these joints, which will arise from the bones, any fracture, fusion, um, displacement of this articular disc could also risk towards trismus development. There are several causes of trismus. Etiology varies, but in an easier way, it's classified into intra-articular and extra-articular. The intra-articular causes are those causes within the joint, as I explained earlier, which could be from fusion, which that's ankylosis, arthritis, degenerative changes within the joints, any meniscus pathology. Then we also have the extra-articular causes, which are they vary depending on the presentation of the patient. The extra-articular causes could be from infection, resulting infection. There's what we call the odontogenic and non-odontogenic. Odontogenic are infections that arises from the gum, the teeth, within the oral cavity, and non-odontogenic that arises from other places, like from the meninges, that from examples, we have meningitis, brain abscess, tonsillitis, etc. Then trauma as well could also result in trismus. If you remember, even from my explanation, fracture either of the mandible or of maxilla, zygomatic arch of will also result in trismus, reduction in range of motion, which obviously can lead to trismus. Dental treatments as simple as post extraction, tooth extraction. So it could also, if there's any because sometimes in some extraction local anesthetics is being administered to the alveolar nerve. It can also cause irritation, spasm, and as well lead to trismus, inflammation, and then trismus. Temporomandibular dysfunction, trauma to the TMJ, then tumors are one of the most common cases that we see trismus um, cases, because most especially tumors, oral tumors around the carotid and the jaws, the joints, TMJ. There's what we call submucous, oral submucous fibrosis is a benign tumor. It also causes severe trismus in patients. Then drugs as well, secondary effects of some drugs like the metoclopramide, halothane, which is an anesthetic, phenothiazine will also result in trismus, radiotherapy and chemotherapy. I said tumors are one cause, the major causes of trismus in patients. So, and these patients most times have to undergo radiotherapy or chemotherapy. And during those sessions, osteonecrosis will occur from those treatment sessions. Post-radiation fibrosis all lead to trismus in such patients. And that's why it's physiotherapy is very important in patients undergoing radiotherapy for oral cancers. Then congenital cases like hypertrophy of the coronoid, Trismus pseudocamptodactyly syndrome. There's also another congenital syndrome known as the Perry-Robin syndrome. This group of patients, because of poorly developed mandible, sorry, they come down with trismus. Then so we've understood what the etiology is. Then what are the clinical manifestation? Its clinical manifestation varies from all, just as the causes varies, the clinical manifestation varies depending on the cause of the trismus. But a major marker, a major pointer of trismus in patients is pain. Pain, the location of the pain. Mostly they report them having pain at the jaws. They point out to the areas of the jaws or around the muscles of mastication, and mostly they say, okay, I'm having difficulty opening my mouth to feed, or while chewing, I feel pain, and they point out to the areas of the jaws. So then others, as we said, interstitial distance is what is used to grade to measure if trismus is there or not. So reduced interstitial distance, impacted of curious teeth. Remember, we have dental treatments that could cause trismus, and sometimes not even they might not have even undergone dental treatment due to poor oral hygiene. They could develop curious teeth. So when you identify them, that's for proper, so that you will be able to give proper referral to appropriate physician. Inability or difficulty to chew food, as I explained, diffuse facial swelling and fever. Remember, infections will also result in trismus. So fever will, patients will come with fever. Chin deviation or facial asymmetry could be seen most especially if the trismus is one-sided. Micrognatic mandible, that's a poorly developed mandible or small chin, as we can see in this picture. Then severe malocclusion or anterior open bite. You ask the patient to put their teeth together, front the to put their teeth together, the front part of the teeth, they cannot move. You can see that open gap. The posterior teeth are coming together, but the anterior aren't coming together, as we can see in this picture. Poor oral hygiene, speech impairments. Remember, if mouth cannot open, speech cannot be coordinated, poor feeding habits, psychological problems, all these, the poor feeding habits, poor oral hygiene could push patients to points of depression and even isolate themselves from the public. It can also result in stigmatization, which can result in these psychosocial problems. So how then can we assess? I've discussed some of the assessment methods, but as clinicians, uh, just like the way we assess every other clinical conditions, history taking is very important, both medical and dental history, in order to identify, to be able to have idea on what led to the trismus development. Remember, pain is a key marker, so identifying the onset of the pain or discomfort explained by the patient, the nature of that pain, progression, how does the pain progresses, alleviating and relieving factors, history of radiation, dental treatments, all those will give you a clue on the cause of. Remember, we said some drugs, secondary effects of some drugs would result in trismus. Then because of that inability to open the mouth, it's not just the oral function that it affects. Compensatory movements, remember, some part of the neck muscles assist in opening the mouth. So that effort being put into open the mouth when it's difficult will also result in strain of some neck muscles. If not strain, tension could arise, and then even poor posture. Poor posture, some patients adopt a kind of poor posture because of trying to open their mouth, so which could also cause tension, tightness in some of the neck muscles. resulting in pain, not just neck muscles, the shoulders, and even the back muscles due to poor posture. Then for the objective examination, it's important to assess intra and extraorally. Let's start extraorally, palpating the jawline and to assess for movement, mobility at the joints, and to palpate the TMJ, we can see it in this picture, placing the fingers at the triangles of the air in front of the triangles. We can all try it. You can feel the movement of the jaw, opening and closing of your jaw. So palpates for any for immobility, or reduction in range of movement, any sign of crepitations, um, pain. Then palpate the muscles of mastication, around the muscles of mastication for any tightness, pain or spasm. Then for assessing, we've talked about the jaw mobility. Then intraorally, you assess the teeth, the jaw for any um, foul odor, mouth, because some of them really present with mouth odor due to that poor oral hygiene. Then some might even tell you they have what do they call it? Sorry, um, foul discharges due to infection from the mouth. So assess all those things. Then the neck mobility is very important to assess for neck mobility in case of pain in the neck, shoulder, and the back as well. I've discussed some of the tools and skills, some of the tools, the measurement tools that we use to assess Trismus, the ruler, the vernier caliper. Also have pain rating scale. As far as pain is concerned, it's important to assess the level of pain. We use the pain either Barber rating scale, numeric rating scale to assess the extent of pain in patients in order to have a direction while you begin treatment. Then there's what we call the Gothenburg Trismus questionnaire and the mandibular function impairment questionnaire. These two questionnaires did not only assess trismus at level of impairment, also assesses function, the basic function of swallowing, eating, chewing, oral hygiene. It assesses those functions, so it helps you understand the quality of function that the patient has. Then we also have to assess the level of trismus, the modified Malampati scoring. There's also the trismus classification system that helps grade the level of Christmas. Then several radiological examinations could help in confirming the diagnosis of trismus, most especially if the cause is intra-articular. For intra-articular cases, we have the OPG, which we call in short for orthopantomograph. It's a type of X-ray. There is dental X-ray that helps shows the symmetry of the mandible and the maxilla. We could see the TMJ here. This is the head of the mandible, the glenoid fossa of the temporal bone, famous part of the temporal bone. This one is for the right and this is for the left. We could also see the dental alignments here. So that's the essence of the orthopantomograph. Then we also have the CT scan. Here is the CT scan. Here we could see the CT scan helps to give a better information of what's happening at the jaw. If there's a fusion, it gives a clearer in different planes, coronal, sagittal, even 3D reconstruction of the joints as well. So now we've understood what trismus is, what is causing the door to refuse to open, and now we have to talk about how to unlock this door, how to unlock the jaw. So the treat management approaches for Trismus. I will discuss these management approaches briefly because today our focus of discussion is on physiotherapy management. In acute cases, pain, because it's a major marker, the main goal is to relieve the pain, reduce the pain to the barest minimum you can. And so pain management techniques are being employed, and relaxation techniques like using of heat therapy, analgesics, aspirin, and in severe cases, narcotics are being prescribed. Muscle relaxants in cases of severe spasms that are causing that trismus, and antibiotics in cases of infection. Then for dental treatment in cases of tooth caries, plaques, and so on. Surgical management, most especially if the cause of trismus is intra-articular, surgical management is indicated. Um, there are several approaches, some of which are condylectomy, gap arthroplasty, and choroidectomy. Then the what are physiotherapy? Now we'll discuss the physiotherapy approaches. For the physiotherapy approaches, we have to know physiotherapy is indicated in every phase of trismus, be it in the acute phase, in the chronic phase. In the acute phase, remember the goal is to reduce pain to the barest minimum. We also have our pain relieving techniques, relaxation techniques that we could also employ. And in chronic phase, we'll discuss all what physiotherapies can do. Then the major goals, remember, pain is first relieving pain, improve circulation, edema reduction, soften and stretch scar tissue in cases where they are from trauma. Those recovering from trauma having trismus, they might have this scar tissue, increased joint range of motion, which is very important for function. Strengthening the muscles is not just trismus. Unlocking the jaw is not just increasing the range of motion, but also strengthening those muscles. Because when there's no restriction at the joint, or no bony restriction, and the muscles are weak, it will also result in trismus. So strengthening of the muscles of mastication is very important, and the whole essence of this is restoration of optimal jaw function, and eventually posture correction in patients that come with poor posture, like the forward head posture and rounded shoulders. Some of them come with those kind of postures. So posture correction, very important. Here are some of the approaches in physiotherapy that we use: the manual therapy, exercise therapy, mouth opening devices, and adjuncts like ultrasound therapy. So for manual therapy, we have the mobilization techniques. The whole essence of manual therapy is pain relief, relaxation, provide relaxation, increase extensibility of soft tissues, to improve jaw mobility. So we have the mobilization techniques like the Maitland's grading 1, 2 used for pain relief, and 3 to increase range of motion. Massage and myofascial release techniques, remember, for relaxation, release tension in soft tissues like muscles and fascia. And the manual stretching, there's what we call the finger spread techniques, which you can see here. This could be done by the physiotherapist or even the patient himself. It's one good home program given to patients with trismus, using the thumb of one finger to on the upper jaw, and then the index finger on the lower jaw, and apply equal pressure, pushing using the thumb to push the jaw up and the index finger to push the jaw down. You can try it and feel the stretch at the jaw. Then exercise therapy, therapeutic exercises that include active range of motion exercises. Very important. Remember, we said strengthening, not just improving range of, but strengthening of the muscles. So isometric contractions, are been said to be essential for maintaining and improving jaw function. And these exercises are often tailored to individual needs and are performed under guidance of physiotherapists. For the exercise therapy, majorly is done based on, remember, the jaw functions, elevation, depression, that's opening and closing of the mouth. It could also be done isometric exercises could also be included when you open against resistance, lateral deviation, side to side movements, protrusion and retrusion, forward and backward movements. You could apply manual resistance in every direction of this movement. 15 to 20-second holds, 5 to 10 repetitions in a session performed 5 times daily. Then we have what we know as the Rokabadu exercises. This exercise is very essential because it does not just cover the trismus, part of the trismus, but it also covers posture correction, and it encompasses active range of motion exercises and breathing techniques. It is also known as Rokubado 6 by 6 exercises, reason being that there are 6 exercises in this Rokubado exercises done 6 times, 6 exercises repeated 6 times and done 6 times a day. That's why it's called Rokubado 6 by 6 exercises. So we have the first exercise in Rokubado exercise is the deep breathing exercise. Um, Before these exercises are being performed, it's essential to ensure that the patient is in a resting position, the patient is relaxed, either in sitting or in half sitting, sitting or long sitting or half lying position. Ensure the patient is well relaxed, and then ask the patient to put the mouth in a resting position. The resting position of the mouth is when the teeth are together. You can see the front teeth being together and the tongue resting on the against the palate. So, and then ask the patient to take in 6 deep breaths slowly, hold for 6 seconds, and then exhale through the mouth. Done 6 times. Remember, Rokubado is 6 by 6, 6 times. 6 exercises done 6 repetitions 6 times a day. So the next is the control of jaw movement. In the control of jaw movement, um, remember the mouth in resting posture, teeth together. You can see the teeth together, the front teeth together, tongue resting against, and then ask the patient to open slowly and close the mouth. Opening and closing. If you try, you can see that your jaw movement is as against just starting without resting the tongue against the palate, and opening and closing lateral. Remember, all the jaw functions will do that 6 times. Remember, 6 times daily. Then just strengthening is the same thing, the same active exercise we talk about, opening and closing, but here manual resistance is being applied. In opening, you put your tongue against your upper jaw. Sorry, you put your hand beneath your chin and then open against the resistance of your hand. Then in closing, closing the mouth, put your hand, 2 fingers on the on your lower jaw and try to close against the resistance of the jaw. Then side to side movement, place when you are doing the right lateral movement, you place your hand on along the jawline, the cheek, and then push your jaw against the resistance of your hand, of your 2 fingers. Then we could do for the other side as well. We have the exhale neck. Remember, I said this Romopado exercise is not just about active mouth exercises. It incorporates posture correction. So remember, some patients can come down with neck pain and back pain, which you could also tackle, help reduce the tension around there. Then there's the exhale neck extension. Patient puts 2 palms at the back of the neck and try to extend slowly. Even you can feel the relief while trying to extend against your hand. Then the chin tuck, try bringing the chin, just simple extraction by telling the patient the head should be neutral, not extended, not flexed, just neutral, facing forward, and ask the patient to try to bring the chin to the neck, chin tuck. This helps when the patient has a forward head posture, helps to correct that. Then the shoulder posture, some come with rounded shoulders due to prolonged poor posture. So there's the shoulder exercise, protrusion and retrusion. I mean retraction, protraction and retraction of the scapula. Remember, all these exercises should be done 6 repetitions, 6 times um, daily. So we also in management of trismus, because trismus could be mild, moderate, or severe, and in moderate to severe cases, exercises and manual therapy aren't sufficient enough to resolve trismus cases. So mouth opening devices are very important components of interventions. They are used in combination with other interventions. They apply mechanical force, stretching the elevator muscles by just pressing the mandible. So the whole essence of this mouth opening devices is they provide a mechanical force that stretches both the elevator muscles and the depression muscles. So some of these mouth opening devices, it ranges across various settings. We have a threaded tapered screw which is placed between the posterior teeth, and you can see in the picture, and gradually it has a screw that you turn to increase the opening. Then we have the screw type mouth gag, the same way put at posterior teeth and is being screwed to provide a continuous and inelastic force. This is done for a short period of time. Then for the wooden tongue depressor, it helps to provide a prolonged stretch to the mouth. So they are stacked, usually used as a wedge or as a mouth prop to sustain maximum mouth opening. Then we also have what we know as the terabyte jaw motion rehabilitation system. It is a jaw or what you know as a jaw exerciser. It's a patient operated device used for passive rehabilitation of the TMJ. And this terabyte has shown greater efficiency in improving mouth opening, especially those patients with sustained trismus. And this terabyte jaw motion rehabilitation system, it has wide flexibility of uses. It could be used as a passive. All the exercises are passive, or it can also you could add resistance. It has an adjustment knob that you could add the resistance that the patient could feel while performing the opening and closing exercises. And then it has a range of motion scale at the side that helps track the progress for the patient. We have other adjuncts like the ultrasound therapy, which is used to relieve pain, reduce stiffness, and increase tissue extensibility. And chewing therapy is also included for patients, like giving the sugarless chewing gum as a means for providing lateral movement, side to side movement, chewing. So here it's all about the efficacy of all these interventions I've mentioned, the exercise therapy. There are studies that have been done that have shown significant improvements in patients, even with the mouth opening devices, the manual techniques. But however, the limitations of available research is that most of these studies are done in patients undergoing radiotherapy or chemotherapy. That's patients with undergoing cancer treatment. Most of these studies are done for such patients. Only few studies are done in other causes of trismus. So in conclusion, trismus is also called lockjaw. It is characterized by restricted mouth opening and can significantly impair quality of life by affecting eating, speaking, and oral hygiene. I can tell you for sure because I work with patients on a daily basis who have this who are dealing with this trismus, um, both children and adult cases. This trismus has varying etiologies and treatment and is targeted for symptom alleviation, as we've discussed. There are evidence-based physiotherapy approaches. They've shown effectiveness in improving this mouth opening and reducing associated symptoms. However, as I stated earlier, there's need for further research to establish standard protocol in trismus management for clinical practice guidelines. So there's no like clinical practice guideline for management of trismus. All interventions are just have not been coordinated together, and as I said, most of these researches are done in particular cases rather, and as we saw during the course of this presentation, there are varying causes of trismus. So even if you have not taken anything from this presentation, my major takeaway for you is to know that trismus is more than a mechanical limitation. It's a barrier to nutrition, communication, and connection. So when next you see a patient with this condition, you shouldn't be helpless. You should know that physiotherapy plays an essential component of rehabilitation care in this group of patients. References, and thank you for listening.